Hi, welcome to today's presentation on hypertrophic cardiomyopathy. Now, hypertrophic cardiomyopathy is an autosomal dominant genetic disorder which is characterized by an asymmetric left ventricular hypertrophy, usually associated with impaired diastolic filling. Now, with autosomal dominant inheritance here, we mean that you require just a single defective gene from a parent in order to get this disease, as opposed to an autosomal recessive disease where you require two defective genes from parents in order to cause this disease. And so the main problem with hypertrophic cardiomyopathy is that there is impaired relaxation of the myocardium due to the hypertrophy of the muscles. With the epidemiology, we find hypertrophic cardiomyopathy once in about 500 people, and males are usually affected more than females, though the female population may be underdiagnosed. It is also found commonly in Afro-Caribbeans as well as Asian populations, and a subtype of hypertrophic cardiomyopathy, which is the hypertrophic obstructive cardiomyopathy, is seen in about 25% of all the cases. And this form of hypertrophic cardiomyopathy is the most common cause of sudden death in the ages below 35 years. So, how do we identify the causes of hypertrophic cardiomyopathy? Now, mostly, as we've seen, is genetic. And so hypertrophic cardiomyopathy is a genetic cardiovascular disorder and is inherited in an autosomal dominant fashion, as I've already explained. And in this case, we have a single normal amino acid which is replaced by another. And in these mutations, usually there occurs in one of the genes, which encodes the myocardial contractile proteins and mutations. And some of these or specific, proteins which are affected in this hypertrophic cardiomyopathy are the troponin T and I, as well as the myosin light chains. And usually, when the mutation is in troponin T, it results in a high risk of sudden death as compared to the other. And it may not be associated with regional wall thickening. Now, when there is a secondary cause which is identified, usually it may be chronic hypertension. And you shall understand why this is so in a moment. Now, let's quickly go through the pathophysiology of hypertrophic cardiomyopathy. But before that, we must know that we have two main types of hypertrophic cardiomyopathy. We have the obstructive type and the non-obstructive type. Now, with the non-obstructive type, I'll explain using these diagrams over here. So the first diagram up here, as the pointer is showing, this is a normal heart with normal ventricular chambers, as you can see, and you can see that the walls are also normal. There is no dilation, there is no hypertrophy of the chambers. So this being the left ventricle, the interventricular septum, then the right ventricle. When we look at the heart on the left in slide A over here, what we find is that the muscles of the left ventricle is enlarged, and this is usually seen in hypertrophic cardiomyopathy. And so when it is non-obstructive hypertrophic cardiomyopathy, this is usually how we find the heart. And because of the enlargement of the muscles of the left ventricle, we see that the chamber of the left ventricle here is reduced. Because of this, little amount of blood enters it from the left atrium. And so the left atrium is unable to empty its content completely into the left ventricle because there is no space to accommodate all of them. When this happens, the left atrium still contains or still has in its chamber some reserves. And so there is a backflow of the blood into the pulmonary veins and into the lungs, causing pulmonary congestion over there. Now, once there is pulmonary congestion in the lungs, it reflects back into the pulmonary arteries, and so there is always pressure, increased pressure inside the pulmonary artery. Now, before we continue, there is also very little amount of blood which is leaving the left ventricle into systemic circulation because it receives very little amount of blood. And though there is no problem with contraction of the left ventricle, the amount of blood which leaves the left ventricle at any point in time is so reduced. And so major organs of the body, such as the kidneys and the brain, for example, become hypoperfused. And so they begin to dysfunction. And in this situation, the kidneys may respond by activating the renin-angiotensin system. And so with this, you find out that it eventually leads to increased blood pressure in such patients. Also, we realize that since very little amount of blood leaves the left atrium into the systemic circulation, small blood gets into the coronary arteries to perfuse the heart itself. And so these patients may present with chest pain as symptoms of ischemia. Now, when we move to the diagram on the right, which is the B, we find that there is hypertrophy of the left ventricle, all right, but we can also see that the interventricular septum is much dilated, or the interventricular septum is much hypertrophied. So even though there is hypertrophy of the ventricle, the septum is also hypertrophied. So the problems over here is that we are going to have decreased cavity inside the left ventricle, as well as obstruction to the flow of blood from the left ventricle to the aorta and to systemic circulation. So all the problems that we find in the first type of hypertrophic cardiomyopathy will also be found in hypertrophic obstructive cardiomyopathy, as well as obstruction. And so usually these patients will have limited amount of blood which is leaving the left ventricle into the systemic circulation because there's an obstruction. Now, why does this happen? This happens for two main reasons. Now, when there is contraction or during systole, the hypertrophied septum flattens out to become broad during contraction, thereby blocking the entrance of the aorta. So right now you can see that it's even not flattened so much, but during contraction the whole of this side of the intraventricular septum moves up, and so it obstructs the outflow of the left ventricle, thereby impeding blood to enter into the aorta, into the rest of systemic circulation. Another important reason is that the anterior mitral valve leaflet, this anterior mitral valve leaflet, what happens to it is that during contraction, it pulls itself, or it is pulled towards the hypertrophied septum, which may lead to obstruction. And so we call this the systolic anterior motion of the mitral valve. And these patients are usually prone to getting mitral regurgitation because once the mitral valve has been pulled towards the septum, blood can easily flow backwards into the left atrium during contraction. Now, in most of the cases, the hypertrophic obstructive cardiomyopathy causes sudden death, as I explained earlier on, in the ages below 35 years, especially if the person is an athlete. This is because during severe exercises, the cardiac output falls and most of the blood is pushed to the periphery. And so if there is an obstruction, as we've explained over here, what happens is that very little blood goes out of the left ventricle, and as such, there is reduced myocardial perfusion. So ischemia sets in and it leads to sudden death of such athletes. We've seen a lot in history. So this is what actually occurs in hypertrophic obstructive cardiomyopathy. Now, I also mentioned that if there is a secondary cause of hypertrophic cardiomyopathy, it is usually chronic hypertension. So, how do we differentiate between this form of hypertrophic cardiomyopathy from the one which is caused by chronic hypertension? Usually, what we find is that in hypertrophic cardiomyopathy or in left ventricular hypertrophy caused by hypertension, the myocytes on histology are enlarged and are arranged uniformly. However, when we do same for hypertrophic cardiomyopathy, which is caused by this primary abnormality of the myocardium, we find that the myocytes are arranged, or the myocardial fibers are arranged in a chaotic fashion and they are disorganized. Also, we find that the hypertrophy is typically asymmetric or localized, as we've just seen. So it can be in the septum or it can be in the mid cavity hypertrophy. So this is the main way that we can differentiate between chronic hypertension as a cause of hypertrophic cardiomyopathy or left ventricular hypertrophy and primary myocardial damage due to hypertrophic cardiomyopathy. Now, how do we identify these conditions? What are the clinical manifestations of hypertrophic cardiomyopathy? Now, majority of the patients are asymptomatic. They don't show any signs of it. But when symptoms occur, left ventricular wall thickness will be seen, especially on echocardiography. Then also we are going to see that sudden death may be the first presentation. And so when we go into it and do the investigations, we may find that the patient actually had hypertrophic cardiomyopathy. And usually, as I explained in the pathophysiology, when symptoms occur, they present similar to that of aortic stenosis. And so you may find left ventricular outflow obstruction. The patient may also, show signs of angina. And angina, as I explained, is because the left ventricle, when it contracts, pushes little amount of blood into circulation, and so the coronary arteries receive very little amount of blood to perfuse the heart, hence the chest pains that the patient may exhibit. We may also have dyspnea and as well as presyncope and syncope on exertion. Yes. Then we may also find arrhythmias, specifically atrial fibrillation, due to conduction abnormalities in these patients. Then the sudden death may also ensue. Now, on physical examination, what do we find? We find a jerky pulse when we check the pulse, and also we find that there is palpable left ventricular hypertrophy. And we may also find double impulses. We may find double impulse when we check by, and this double impulse usually is caused by the combination of the contraction of the hypertrophied atrium as well as the ventricles. That is how come you get this double impulse at the apex of the heart. Then we also have pansystolic murmur due to the backflow of the heart, of the blood through the opened mitral valve. And how do we investigate these hypertrophic cardiomyopathy? Now, our first line of investigation, as we learned before, is the use of echocardiography. So echocardiography is the first best step or first best diagnosis that we can use in hypertrophic cardiomyopathy. And what do we see on echocardiography? Echocardiography will show us dilation. It will show, it will not show dilation as we find in most cases of dilated cardiomyopathy, but we may find that there is left ventricular hypertrophy with left ventricular outflow obstruction, as well as the systolic anterior motion, which I explained. And they may also be abnormal systolic and and diastolic left ventricular function. So this is what we see on echocardiography. Then speckle tracking will also show us decreased longitudinal function as well as an increased circumferential and radial function. And interestingly, diastolic function will also be seen in speckle tracking. Now, on ECG, what we find is that though the changes are not specific, we may find left ventricular hypertrophy as well as T-wave inversion in some of the patients. Then also on chest X-ray, as we explained before, chest X-ray usually will give us signs of heart failure, which we saw in our previous tutorial as the A, B, C, D, and E. So that is it. Then we can also do the genetic testing to rule out any genetic abnormality or mutations. Now, we do genetic, testing by screening first-degree family members. Provided that a disease-causing mutation is found in some of the first family tree of these patients. Then our other investigations that we can do include the blood analysis, including liver function test as well as electrolytes, and also blood or B-type natriuretic peptide. And if B-type natriuretic peptide is found in any of these patients, it may indicate that the patient is having a heart failure. Then we can also do the thyroid function test, since we said hypothyroidism can also cause some of these problems. Now, our second line of investigation is to do the cardiac MRI. And MRI is useful for evaluating the ventricular wall thickness and the presence of replacement of myocardial fibrosis. So that's why we employ MRI in the diagnosis of hypertrophic cardiomyopathy. Now, let's quickly look at some of the echocardiography signs of hypertrophic cardiomyopathy. As you can see over here, in the first slide, you can see a hypertrophied interventricular septum over here. And since there is hypertrophied interventricular septum, as the arrow is pointing over here, this interventricular septum is measuring more than 43 millimeters, as you can see over here. And so this poses the problem of obstruction of the left ventricle. So blood cannot leave the left ventricle to the systemic circulation. Now, when we look at the slide on the B, we can also see that there is obstruction of the left ventricle, and we can see that there is actually massive hypertrophy of the left ventricular wall over here. Then also, when we look at the second image, starting from A, this echocardiography was taken from a patient with severe symptomatic obstructive hypertrophic cardiomyopathy, and the A slide was taken during diastole, and it shows a marked increase in ventricular septal thickness, as you can see over here. Then the B was taken during diastole, and it also shows systolic anterior motion of the mitral valve that causes obstruction of the left ventricular outflow, as you can see the arrow pointing here. So you see how the hypertrophied septum obstructs the outflow of the left ventricle, and how the mitral valve has been pulled towards the septum over here. Then also on the C, we can find the M mode echocardiogram, which is showing prolonged mitral septal contact during systole. Then the D also is a Doppler echocardiographic recording in the outflow tract that demonstrate a peak instantaneous, pressure of about 130 millimeters per mercury, as the arrow is pointing over here. So basically, these are some echocardiographic signs of hypertrophic cardiomyopathy. And looking at the ECG signs of hypertrophic cardiomyopathy, as you can see here, there is evidence of left ventricular hypertrophy. Look, we can use the Sokolov-Lyon criteria to check, because as you can see, there is so much, the R wave in V5 and V6 are so long. So we can take the R wave in V5 and we count. We are getting 5, 10, 15, 20, 25, 30. Then we add this to the S wave in V1 and we are getting 5, 10, 15. So 15 plus 30, we are getting 45, which is more than what we expect. The normal should be equal to 35. So any, measurement that is more than 35 indicates that there is left ventricular hypertrophy, and in this case, in hypertrophic cardiomyopathy. So it is always advised that in a young patient who presents with exertional symptoms such as lightheadedness and palpitations and has an ECG which looks like this, the first thing that must come to your mind is hypertrophic cardiomyopathy, other than thinking of a lateral infarction or something. So this is pointing to a hypertrophic cardiomyopathy using the Sokolov-Lyon test. Okay, so that is it. Then on this ECG as well, what we can find is that there is high precordial voltages over here. So when you look at V4, V5, see that the voltages are so high. Then also we can see deep T wave inversion in the precordial leads, as well as the high lateralis. So you can find inverted T waves over here. This is a very big or deep inverted T wave in precordial lead 5 as well as in lead 4. You can see subtle T wave inversion in lead 6. You can also find it in standard lead 1, in lead 2, as well as in AVL. And there is also evidence of left atrial enlargement as shown in P mitralis. So you can find it over here. You see the P wave looks like M, pointing towards left atrial enlargement. And this left atrial enlargement, as I've explained, is because very little amount of blood enters the left atrium, and so the very little amount of blood enters the left ventricle, and so the left atrium at any point in time contains a lot of blood than expected, and so it may cause its enlargement. So that is what we can find on this ECG, pointing towards hypertrophic cardiomyopathy. Now, how do we manage hypertrophic cardiomyopathy? Now, we need to manage the left ventricular outflow obstruction as well as the systolic anterior motion. So what do? We must initiate the use of beta blockers as well as calcium channel blockers, and we use the beta blockers to help reduce the rate at which the heart is contracting so that it can take its time to fill with enough blood and pump enough blood into circulation. Then we can also use the calcium channel blockers. Specifically, you can use the verapamil, which will also reduce the workload of the heart. Then we have to treat heart failure, and as we saw earlier on, we treat heart failure with AABD. The first A for AC inhibitors, or we can choose ARBs. Then we can go for beta blockers as well as the diuretics. Now, other treatment options include the surgical myomectomy or surgical myectomy. We can do this, in some patients when medical treatment, does not respond. Then we can also do the alcohol septal ablation. This method is not so popular. It's not done in almost everywhere, but it's one of the methods that we use in the management of left ventricular outflow obstruction. And what happens over here is that alcohol is injected directly into the coronary uh, you know, alcohol is injected directly into the interventricular septum, and so it causes an iatrogenic, myocardial infarction to reduce, the septum, thereby paving way for blood to leave the left ventricles through the aorta into the rest of circulation. We can also, go for heart transplant for these patients, as well as the implantable cardioverter defibrillators. So this is the main way of managing hypertrophic cardiomyopathy as well as hypertrophic obstructive cardiomyopathy. Now, we need to also try and prevent complications such as the arrhythmias. And so what we have to do is to give antiarrhythmics, for any atrial fibrillation. Then example of what we can give is to give warfarin to prevent, the thromboembolism in these patients. Now, with this condition, we need to advise the patient on lifestyle modification because, as we said, it usually occurs in young adults. And so, if the patient is an athlete, then we have to advise the patient to reduce the number of activities in order to avoid a lot of strain on the heart. And so, we need to really advise them on lifestyle modification to, prevent sudden cardiac arrest. Then when we look at the prognosis, we find that competitive sports may be, a risk, and it may precipitate sudden death. And so this is why, as I have explained before, we need to tell the patients to avoid such activities. And the annual mortality is between 2 to 3% among adults and 4 to 6 percent among children and adolescents. So this is all that I have for you for hypertrophic cardiomyopathy. Thank you very much for your time. Bye bye.